Hello and welcome to Ventilator Management. This is Sean Hulsman, paramedic and education guy, and this is a presentation which was prepared by paramedic Dominic Wallenczak. We thank him for that, with the assistance of Scott Leonard, who is paramedic and a respiratory therapist. As you well know, Scott and Don put this together. I'm giving it to you guys, and this is basically what we did for live training for the vents. The point of the training here today is to kind of introduce you to the ventilators if you haven't had a chance to see them yet, and to also go over a little bit of basic background on ventilatory management and why we're using the vents and some of the settings that you might come up with. The objectives for this presentation, you should be able to hook up, turn on, and adjust settings on the vent. That's pretty much what we want everyone to be able to do. That's the most basic part of this. You should be able to describe the difference in the ventilator modes. So we're going to talk about a couple different modes of ventilation. You should be able to replace and remove the batteries as need be. Troubleshoot some common alarms, and believe me, there are many, and they are very annoying. So we'd like to be able to click those off and figure out what the problem is when those alarms pop up there, and have a better understanding or explanation of PEEP as we get to that. If you figure that out, that's great. And then this extra stuff here is pretty much just icing on the cake. If you can understand a little bit of the math and science involved in the mechanical ventilation, that's cool. Defining tidal volume and millimeter volume is something you should already be able to do, but we'll review that. And we're going to explain the need for common ventilator adjustments that you may have to do in the field. Please note, we're going to be matching the settings on our ventilator that are on the ventilator at the hospital when we get there. So when we switch our patients over, we're just matching settings. Any changes that we're going to make to those settings would require consultation with med control. So we're not going to be doing any changes on our own. This is simply us mimicking what the vent at the hospital has on it and going with that. You may well understand what is happening, and you may have a very good reason for wanting to change a ventilator adjustment, but if you do that, you are going to call for medical control and make sure that you have permission to do those things. So, why is a patient on a ventilator? We all know why patients are on a ventilator. They can't control their own airway. There's a lot of different reasons that this could occur. Head injuries, anoxic brain injuries, people who are medically sedated, those patients who we treat in the field or see in the field that have CHF or COPD but aren't able to be treated quickly enough to avoid being intubated, so they become intubated and they're medically sedated. So those are the type of patients that we're seeing when we transport patients who are on a ventilator. There are settings on there. The new ventilators, as you probably have seen, have a whole bunch more buttons and lights and wonderful things there. But basically, there's a bunch of settings to provide proper ventilator settings for the breathing. And there's two processes to breathing. I like to harp on this. I know people know this, but it's important to keep this in mind. There's ventilation, and ventilation is just the removal of the carbon dioxide from the body. This is done through your tidal volume and through respiratory rate. So how much air you're moving in and out over the course of a minute is going to determine how much carbon dioxide gets pushed out of the body, and we're going to revisit that later on in the presentation. The second part to breathing is obviously the oxygenation part, where we're bringing air in with oxygen, and that oxygen is being sent to the tissues of the body. So ventilation and oxygenation are there, and you're going to see settings on the ventilator that have to do with each of those things to make sure they're both happening appropriately. But they are two different processes, and people do tend to lose sight of that occasionally. As far as the science and the numbers behind this, it's not stuff that we need to know as medics, really, but to have a basic understanding of the fact that there is science involved is good. So when we are trying to figure out tidal volume, how much air should go in and out with every breath, that is based on your predicted body weight and usually comes off of a height chart such as this one. So with a height chart, obviously I'm always on the outlining extreme here, but this is my predicted body weight, which actually is a little bit low because I need to hit the gym again. So the predicted body weight for me would be 100.6 kilograms, and these are other body weights. This is just how the respiratory people would determine the approximate tidal volume, how much per breath. The preferred volumes overall are generally going to be in this range. This 6 to 8 milliliters per kilogram is the ideal that we're looking for. So depending on different pathologies, you may find patients who have different preferred volumes, but for adults, this is going to be the volume we're looking for, 6 to 8 milliliters per kilogram for each breath. Tidal volume times respiratory rate equals your minute volume, and we said before that your minute volume is going to control how much carbon dioxide you have. This kind of makes sense. If you are moving a lot of air or too much air over the course of a minute, then you're going to have hypocapnia. You're going to blow off a lot of your CO2 and you're going to end up with respiratory alkalosis. So maybe your pH is going to be 7.5, right? Or if we're not blowing off enough CO2, then we're going to have a pH of maybe 7.2 2. Okay, so these are all bad ranges. Remember that your normal pH range is going to be somewhere in the realm of 7.35 to 7.45. So that's where we're looking to be for pH ranges, and we need to keep that there. Your body does a really good job of doing this on its own. Once you're intubated and you're having somebody breathe for you, it becomes that person's job to make sure that stays put. So the takeaway here is when you have intubated patients, you need to keep watch on your CO2. If you see significant changes on your EtCO2, on your waveform capnography, we need to address those things. This is the real science behind determining how much air is getting in the patient and how many breaths per minute. So here's a scenario. Dom Wallensack suffers an accidental pool-related drowning at the pool in Tonawanda. Pulses have been restored and the patient is intubated. What should be the initial tidal volume respiratory rate? Well, here's your minute volume. This is a constant number right here, 120, and basically they base it on people who are intubated should have about 120 milliliters per kilogram per minute. So 120 times 70.7, which is Dominic's predicted body weight, yields this number here. So 8,484 milliliters per minute. So this is going to be the minute volume. This is how much air should be going in and out of Dominic over the course of a minute. When we're determining tidal volume, as we saw before, we're going to use that 8 milliliters per kilogram. So this is a tidal volume. Each breath should be about 566 mLs. So with these two numbers here, this minute volume and this tidal volume, we can use them to put into an equation and calculate the rate. So the rate of respirations for Dominic, based on those numbers, is going to be 15 breaths per minute. And when you see Dominic on the ventilator, you're going to have all these settings set up for you when you get there with a respiratory rate of 15 breaths per minute. So again, nothing you need to know as a medic or that I need to know, but this is how it's calculated so you can have an appreciation that there is some math and science involved. We don't just pop a ventilator on somebody and breathe for them. End-tidal CO2, as you know, we're looking for an end-tidal CO2 for most patients of 35 to 45. If we have a obstructive pathology, some kind of COPD or asthma happening, a wheezing, we may be looking for a change in that or maybe seeing a different CO2 only because it takes longer for air to be expired. And we're going to target higher rates for acidosis. So let's say you got your patient here in DKA and they have a pH of, let's say 7.1, all right? We are going to want to blow off more carbon dioxide. So maybe you're going to see the vent settings and they're going to be set so that you have a EtCO2 of, let's say 34. All right, and that's where they need it to be. So this could be EtCO2 of 34 millimeters of mercury, and that is what the vent settings are going to look for. We'll know that when we get there, and they'll tell us to check that out. So if we start to see an increase in the EtCO2 as we transport, we're definitely going to want to call the hospital and say, hey, should we increase the respiratory rate or do something different so that we can increase the minute volume and get more carbon dioxide out of the patient. Positive vent expiratory pressure is something you guys should have a pretty good grasp on at this point, but basically it's just pressure left over in the lungs after the end of expiration, ergo and expiratory pressure. So we want to have pressure left over in the lungs. This does a couple things. Decreases airway resistance for the air going in, and it also maximizes recruitment. If you remember what recruitment is, this is us trying to get alveoli to pop open. When you have different pathologies, your alveoli can collapse. So when they collapse, you don't get good air exchange, and the whole point of this is to get better air exchange. Here in A, you see some alveoli that have collapsed, and clearly there's going to be not much good air exchange happening in these. So if we provide some PEEP there, some back pressure at the end of the expirations, we kind of reinflate these, make them nice and round, and we have good surface area inside the alveoli to pop them back open so we can have gas exchange, and that's what we want. Can you have too much PEEP? Sure. All right. We don't want overinflation. That can damage the lungs, damage the alveoli, and cause problems later on there. The other thing that happens is here's your heart, and then here is your right lung, and here is the left lung. When you have too much PEEP going on in the lungs, these start to put pressure on the heart. So you're popping the lungs too full and they're putting pressure on the heart, and this is going to cause a decrease in your blood pressure, which is the reason why when you talk about CPAP, you don't want to put CPAP on a patient who's got a systolic blood pressure of less than 90, because you are adding PEEP, and that PEEP can inflate the lungs and put pressure on the heart and cause your preload to drop, which is going to cause your cardiac output to drop. So too much PEEP can be a problem. In general, as with our protocols, we're starting patients at 10 centimeters of water, and that's what we're going to see for most normal patients. There may be changes based on that, and again, that's something that we're not going to determine, but it'll be determined prior to us getting a patient on the ventilator. Here's a cool video. Peter Lorre, if you don't know, was a guy who was in the movies back in the black and white movie days. He had a pretty distinct accent. You'll recognize it. So this is obviously not Peter Lorre, but the doctor talking sounds like him. And I'll play the video here. You can take a look at this. This is a set of rabbit lungs, and this is what we're talking about when we're looking for good PEEP. All right, so what you're seeing here is the lungs are actually intubated, and clearly you have some inflation of the lung with the ventilation. So when air is being put in there, you got this area here that's inflated. That's good. That will be an area where you would get good gas exchange. Here's another area where you would get good gas exchange. That's all great. But notice that you have these areas here and up into here that are all deflated still. All right, so this has not been a full inflation of the lung, which means all those areas I just indicated are not going to be doing gas exchange. This is bad for a patient because you're not getting the full capacity of the lung working. And what you'll see is that this doctor is going to then put PEEP on, and when he puts that on, you're going to see that the lungs will inflate more fully. All right, see how pretty that is. So all this lung tissue now is inflated. So we don't have any more of these areas that are deflated, and this is going to give us a full use of the lung tissue, which means that the patient is going to now have good airflow in and out and good oxygen and carbon dioxide exchange. When he takes the PEEP off, again, you're going to see a full deflation of the lung. All right, so that's pretty much what we're doing when we're trying to put PEEP on a patient. That is what CPAP does for your patients, and that is what PEEP on the ventilator setting does for your patient. So your glottic opening normally provides you with some PEEP when you're just a healthy adult here. So think about the glottic opening, all right, and we look at, here's your arytenoid cartilages there that you would see when you're looking in there, and here's the vocal cords. All right, this area right here where the vocal cords and your glottic opening has a limited diameter. So your air moves through there, and that causes a little bit of pressure when you breathe out. So that is what's called physiologic PEEP, and it's usually somewhere in the realm of 3 to 8 centimeters of water. So that's usually physiologic, what you would have in a normal patient. All right, that's awesome. Once you intubate somebody, however, we have taken that away, right? So instead of having these vocal cords in there, what we're really doing is just you have a diameter of your ET tube opened up in the airway there, and you don't have anything to cause resistance. So air goes in and out pretty freely, and that causes a situation where you have zero PEEP. All right, and what we saw with the previous video is that zero PEEP means collapsing of the alveoli, which is not good for your patient. So intubation bypasses that glottic PEEP, and then we're going to try to fix that by supplying artificial PEEP. On the ventilators, you're going to be plugging oxygen into it, and the new vents are nice because we can actually titrate the oxygen that we need to get somebody where they want to be. Now, hyperoxia is bad. I think we all have a pretty good understanding of that now. We don't want people at 100% oxygen. It's not good for them. So what your respiratory therapy people are going to do is start usually at 100% oxygen, and then they're going to titrate that down until you're getting SpO2s of somewhere in this range, 94 to 98%. That's where they want to be. So room air, as we know, is 21% oxygen. When you get to the hospital and you find somebody on the vent, they may have a FiO2 of, let's say, I don't know, 75, right? So that means they're getting 75% oxygen, which is allowing them to maintain this. And if that's too much, if this goes up to 100, they may drop that more. So this is going to be titrated based on this number, the SpO2. Again, this will be there before we get there. So when we get to the hospital, we're just going to have an FiO2 setting. There's going to be oxygen hooked up to the ventilator, and we're going to have a specific percentage of oxygen that's being supplied by the machine, and that's a setting that we're just going to adjust our ventilator to match. Couple different modes, and modes are important because modes tell you a little bit about how the ventilator works. So the first mode is continuous mandatory ventilation, a CMV. You're familiar with this mode because this is basically just a automated bag valve mask. So you have three settings on this old vent that we used to use. You have your breath per minute, you have how long it takes to put those breaths in, you've got tidal volume. That's it. Basically, we are breathing through a box for the patient at a specific rate. The drawback to this is that there's really no working with the patient. It's kind of unforgiving and it's not good for patients. And basically every couple seconds they're going to get a breath of a certain volume, whether they want it or not. So that is the old machine. As we'll see in a minute, having continuous breaths going in is bad for your patients because most patients are not without some kind of respiratory effort, even when they're sedated, and they will try to breathe against the vent at some point, and that will cause them to freak out and desaturate, and all kinds of bad things can happen there. So CMV is pretty much obsolete at this point. We're not really seeing that anymore, and that's the main reason why we got rid of these old ventilators. The most common mode right now that we're seeing is assist control, or AC. It's beginning to be replaced by a different mode as well, but it's still the common mode that you're going to see in adults. And it's similar to CMV in that it does deliver time cycled volume. So you're 16 times per minute or whatever, you're going to get a fixed tidal volume. However, the patient can trigger a breath. So if the machine has just given a breath and the patient tries to breathe again, the machine will allow them to take another breath. Drawback to this is it's going to give them the full tidal volume it's set for. So if they just got a 500 cc breath from the machine as programmed and they try to take a little bit of a sip breath, they're going to get another full 500 from the machine, which can lead to breath stacking. Breath stacking basically means that you've got your lungs full. As the air is coming back out, you breathe again and you refill it with another 500. So let's say you breathe in 500, you're in the process of exhaling and only 100 come out, and then we take another small breath, you get another 500. So now you've almost doubled the amount of air in there. This can cause barotrauma and pneumothorax and all kinds of bad things there. So it's a little bit better of a vent setting because it works with the patient, but it can also cause problems too. The best mode right now that is used with patients who are going to be taking breaths is usually simultaneous intermittent mandatory ventilations, or what they call SIMV. And this maintains a minimum respiratory rate, so they're going to have a specific respiratory rate. It's going to allow them to take those spontaneous breaths on their own. The big difference is here. They are not going to be getting a full pre-programmed tidal volume. So if they take a breath on their own, SIMV allows them to take whatever they want. So if it's just a little gas breath, 100 milliliters or something like that, it's going to allow them to do that. So basically it's any volume, anytime, with a little bit of a minimum volume there. This is not a standalone mode. It's usually coupled with PRVC, which is your pressure regulated volume control. And what this does is, instead of using just a specific tidal volume, it's going to give respirations or breaths until a specific pressure in the airway has been reached, and that's going to cut off. So that's nice because when you are getting a breath, if you reach a higher pressure before you blow a pneumo or have some kind of barotrauma, the rest of that breath gets cut off by the machine. This is more physiologically normal, as they would say. All right, it's coupled usually with a SIMV mode. However, if your patient is taking lots of low, tiny breaths, it'll allow them to do that. So this can cause an hypoventilation because they're not hitting their minute volume targets. So you have to be careful of that. So again, they're going to be determining what the best mode is for the patient at the hospital prior to our arrival, and that is going to be what we're going to be matching with our ventilators when we get there. Ventilator alarms. Oh my God, make the beeping stop. Okay, so there are, as I said before, quite a few alarms that can be triggered, and we'll talk about what they are and how to deal with them. High airway pressure alarm. That means there's just high pressure in the lungs in the system. So this can be caused by a couple different reasons. Kinking in the tubing, with patients coughing against the inspiration, if there's lots of secretions in there. Decreased lung compliance, so they have atelectasis or pneumonia or bronchospasm, and a patient fighting with your ventilator. All right, so the solutions for that. If you have a kink in the tubing, well, you check and replace the tubing. That's great. Coughing is a likely temporary situation. This should stop on its own. You may get the alarm and you can cancel it out and you'll be okay. For secretions, clearly the best thing we can do is suction there. If you have decreased lung compliance, we can use bronchodilators or other medications to try to take care of that. And if your patient is waking up and starting to fight with the ventilator, the real response to that, and honestly this is the response to most situations when your patient is fighting the ventilator, is just more sedation. All right, paralytics alone are not good because the patient is still experiencing that anxiety and that fear of having a tube down their throat. So we're trying to sedate them as well. Paralytics help, but the sedation is what we're going to need to do. You may, on a long transfer, find yourself having to up some sedation if they have a drip of some kind running, or you may have to call for orders to administer additional benzodiazepines to make sure that the patients are comfortable during this process. Low airway pressure. 99% of the time there is this tube, which we'll talk about later on the side of the vent, and that is usually dislodged or something is wrong with that. So the reason why you have low airway pressure, you can have open tracheostomy. The patients become extubated. That will cause low airway pressure. You can have a leak in the tube, so the cuff, tubing, connectors. So if you get low airway pressure that persists, the first thing you want to do is check this tube, make sure it's okay, and then you're basically going to be looking for other signs in your patient. Make sure you still have a waveform, ETCO2 is good, make sure you still have a good SpO2, and try to figure out where the leak might be. Low minute volume. So as we said, your CO2 is controlled by your minute volume. If you have many small breaths that are being initiated by the patient, that can drop the minute volume, which will cause an increase in CO2. If you have a decreased lung compliance, that means you're not moving as much air. But all this is telling you is that based on what it's seeing, you're not going to move the targeted amount of air throughout the course of the next minute. That needs to be fixed as well, because if you're not moving the air, then obviously our CO2 is going to be increasing. So the CO2 goes up when we have low minute volume, and that's bad for our patient because that causes the pH to go down, and that causes acidosis, and life is not good. So we got to figure out what's going on there. Solutions for this: if you have many small breaths, again, the patient's starting to fight the ventilator, they probably need an increased sedation. Bronchodilators can be used for bronchospasm and air trapping. And if you have obstructions or secretions that are stopping air from moving well, then we're going to try to fix those or suction and remove those. Apnea alarm. There is a CPAP mode in this. I don't imagine that we're going to use it very often, but there is a CPAP mode on here, and apnea alarm just means the patient's not breathing. How do you fix that? Make them breathe. So that'll be a ventilation. Pretty easy there. Some special circumstances. Patient ventilator dysynchrony. This is the magic word, just meaning the patient is not working with the ventilator. Again, most of the time this is somebody who's not been properly sedated or whose sedation is wearing off. This is extremely traumatic for a patient. What you're going to see are a couple things in this situation. High pressure alarms are going to start dinging. You're going to start to see tachycardia, lacrimation, which is crying, gagging, coughing, biting on the tube, all those kind of things. All right, here's your panicked patient. So imagine you are waking up in a bed and you have a tube in your throat and you're pretty much paralyzed and you can't move. That's going to freak you out quite a bit. So they start working against the ventilator. It causes their blood pressure to rise. It's basically sympathetic nervous response kicking in. They're going to have increased oxygen demand, increased intracranial pressure. This is bad. You're basically scaring the crap out of your patient. So the best way to deal with the patient ventilator dysynchrony, again, is to try to get pain medications and sedatives on board. We don't carry anything other than Versed and morphine, but we have had medics already who have called for orders and have gotten both morphine and Versed for their patients during a vent transfer because they're starting to buck the tube. So this is something we want to keep a good eye on and make sure that your patient is comfortable during the transport. If they start to show you signs of this, we want to get them sedated again pretty quickly. Breath stacking, we mentioned before. You're going to have high pressures because of that, so your high pressure alarms will go off. You're also going to have low tidal volumes because you're not moving air in and out as much. So there's an alarm on our ventilators called auto peep, and if that's happening, what that means is that you're getting breath stacking. Auto peep is pretty much the same thing. This can cause hypotension because the lungs are pressing on the heart. It can be caused by a couple of different things, but we're looking out for that, and we're going to try to not get breath stacking going on. Some of the things that you can do if you get breath stacking are burping the vent. So basically you disconnect the tube from the vent for a full second or so and let a full exhalation of the lungs occur. You can shorten the inspiratory time, which we'll show you in a little while, but if you shorten the inspiratory time, it prolongs expiratory time, so it gives the patient more time to breathe out. And if you have some kind of obstructive pathology, you can give bronchodilators as need be. You can also have what's called an inappropriately triggered breath. The machine itself has a sensitivity to a breathing trigger, so it's going to tell when your patient is breathing in. If it's set too low, bumps on the road and other movement of the patient can look to the vent like a breath, so it will give a breath, and that can also cause breath stacking. So you may need to change your sensitivity on there And you may also need to change to a different mode if you give medical control to do that. The negative effects of breath stacking are that it increases intracranial pressure, increases your thoracic pressure, and you can cause barotrauma and pneumothorax. So that's not good stuff. Hypotension can occur, and eventually you get cardiac arrest. So we want to fix breath stacking as soon as possible. And if you see that happening, you're seeing signs of that, the alarms that are indicating that, we gotta get it fixed. Loss of capnography. If you lose your capnography, there is a mnemonic that we all know and love very well, but if you lose your capnography waveform all of a sudden, we got to do a couple things. The first thing we're going to do, and it's different from what you probably learned in the past, it's double D. D, dead. So first thing you want to do if you lose your capnography is check for a pulse. Make sure that you actually have a pulse in the patient, because if the patient's pulse goes away, you can lose your waveform. If the patient has a pulse, the next thing we're going to do is remove the vent. So we're going to take the vent off the patient, and we're going to put the bag valve mask on, and we're going to see if we can bag that patient back to a good waveform. If you can, that means a problem with the ventilator itself. So there's something wrong with the ventilator, we have to work on that. We may have to turn it off and restart it, or maybe we're just going to bag that patient for the remainder of the call. If you don't get a return of your waveform with the BVM, then we have to start thinking about tube displacement. So we're looking at placement of the tube, we're looking for obstructions, listening for pneumothorax, all that kind of stuff that comes into dope. So, lose your waveform. Step 1, check for pulse. Step 2, you're going to remove the vent and bag. If that fixes the problem, it's a ventilator problem. If it doesn't, then we're going to go to the rest of dope. All right. Ultimately, if you can't fix this and you're getting SpO2 dropping and the patient's starting to get tachycardic and things looking bad, you ultimately are going to pull that tube. And you're going to try to bag BLS and do what you have to do, or try to get that replaced there. That is the bottom line. We can't let this situation occur very long, because the patient's going to start to get hypoxic and hypercapnic and acidotic. So we should be looking at that first. The first thing you should be looking at is whether they're still having a pulse, and then whether or not that tube is in place. When you switch from the hospital vent to our vent, so you're going to connect the tubing to our vent, the tubing that comes with it. You're going to turn on the vent and try to match the numeric settings. We actually have a lung, it's not a real lung obviously, but it's a practice lung. It hooks up to the vent, so it'll hopefully stop some of the alarms that you're going to get. But you turn the vent on, you're going to match the settings from our vent to the hospital vent, and then you're going to remove the hospital vent from the patient and place our vent on. Once you've done that, stick around. You want to stay at the facility for maybe 5 minutes or so, and just to make sure that the patient is making the switch. The vents they use at the facility are pretty much the same as ours. Ours is just a mobile version of theirs, so it shouldn't be a problem. However, if you encounter a problem with the patient being able to transition to our vent, you would probably rather have that happen at the hospital while the physician and the RT are still there, rather than halfway to the next hospital. So hang out on scene for there about 5 minutes, get your papers together, start doing your stuff there, monitor the patient, make sure that they are making that transition from the previous ventilator to ours okay, and then consult with the physician if you need to take care of alarms that keep coming up there. You're going to transport the patient, and then you're just going to monitor ETCO2, SpO2, vital signs, and ECG as needed, and you're going to take them to the next hospital. That's all. So that is the review of respiratory function and the vents, and the next part of the video is just going to be the demonstration of how to turn it on, hook up all of the attachments, and set things on there.